There we go. And thank you for the opportunity to present here today. I'd just like to begin by acknowledging my wonderful colleagues and co-authors, Professor Judy Curry and Professor Julie Considine, and we are from Deakin University and Eastern Health. So, wearable vital sign monitoring devices are promoted as an emerging patient safety strategy that may improve the early recognition of deteriorating ward patients, and this is through enabling remote continuous vital sign monitoring. So wearable devices have been something that have been studied extensively in the out-of-hospital setting, but little is known about the in-hospital use of wearable devices, particularly those that measure vital signs and patient perceptions of these devices. So, of course, the devices themselves need to be technologically sound, but patients must also be able to tolerate the devices in order to wear them in the way in which they are designed. So as with any technology, the degree to which our frontline users accept the technology is really key to its success. And the image on the right here is just an example of a wearable device. So the aim of this systematic review was to examine patient acceptability of wearable vital sign monitoring devices, and this was through analysis of patient acceptability, patient satisfaction and experience, and this was in the acute care setting. So using the PICO framework, our review had the following. Our population was adult ward patients. The intervention referred to the wearable vital sign monitoring devices themselves. The comparison aspect was non-applicable for us. And finally, the outcomes were patient acceptability, patient satisfaction and patient experience in relation to wearing the device. So a systematic review design was used, and our reporting was informed by the preferred reporting items for systematic reviews and meta-analyses guidelines. We registered our review protocol with Prospero, the International Prospective Register for systematic reviews, prior to commencing this review, and our protocol is publicly available. Studies were identified using the following databases. So we had a look at CINAHL Complete, Medline Complete, Embase, and we also did some hand searching and electronic searching of reference lists of all the relevant articles that we found in order to identify those studies that we weren't able to locate using our search strategy. And all of our search terms were reviewed and approved by all members of our research team, and who are nursing experts, and we also got advice from a specialist university librarian. So studies were eligible for inclusion in our review if they involved adults above 18 years of age, if they involved hospital patients admitted to a ward or the ED, and that included the ED waiting room. It needed to involve a wearable device that was capable of assessing at least one vital sign, and this device had to also enable patient ambulation. And the studies had to report on patient acceptability, patient satisfaction or patient experience data in relation to wearing the device, and studies also had to be peer reviewed. We excluded studies if they involved paediatric patients only, patients in the out-of-hospital setting, patients admitted to critical care environments where continuous monitoring was already in place, such as the ICU or the CCU, or if they involved wall-mounted monitors or mobile monitors that were fixed to stands. We also excluded abstract-only studies, editorials, letters, commentaries, and all of our studies had to be published in English, and we didn't enforce any date restrictions. So our quality assessment of the quantitative studies was conducted using the Downs and Black checklist for measuring study quality. Qualitative studies were assessed using the Critical Appraisal Skills Program Qualitative Research Checklist, and a meta-analysis was not possible due to the heterogeneity of the data from the included studies. So this slide is just showing our Prisma diagram. So all members of our research team participated in the screening process and also in the quality assessment procedures. After the removal of duplicates, the combined database searches yielded 402 studies, and additional 25 studies were identified from hand searching the reference lists of the relevant studies, and title and abstract screening then resulted in 22 studies that were potentially suitable for inclusion, and then full text screening resulted in the exclusion of a further 15 studies, leaving 7 studies meeting our inclusion criteria. So this slide is showing the 7 studies which met our inclusion criteria. So these studies were conducted between 2009 and 2018. All were observational in nature, so specifically executed as feasibility, pilot or evaluative research. All were single-site studies conducted internationally, so in the United States, the United Kingdom, Taiwan and Austria. 6 studies were quantitative research, 1 was qualitative research, and the specific methodology used in the studies was highly variable. In terms of the focus of each of the studies, patient acceptability and patient satisfaction were each explored in 2 studies, and patient experience was explored in 3 studies. Our quality assessments revealed that the overall quality of the studies included in the review was low, so the quality scores for the quantitative studies are included as scores out of 17 in the blue bubbles on screen. So the study populations included general medical patients, surgical patients, ED patients and patients who had recently been discharged from the intensive care unit. All of the studies evaluated different types of wearable devices with very different capabilities. Some examples of some of the designs that were investigated included a textile vest that was paired with a chest belt and a wireless patch that was designed to be worn on the chest. So in terms of our results, so in 4 of the studies the results were predominantly positive in regards to the perceptions that patients had about the wearable devices, and in 3 studies the findings were quite mixed. So most of the positive findings were in relation to comfort and perceived safety. So in relation to comfort, in 1 study 83% of patients found the devices very comfortable to wear. In another, 80% rated the degree of comfort as at least very good. In relation to perceived safety, 86% of patients felt that they felt safe and well taken care of, and in another study 91% felt safer wearing the device. There were some other perceived advantages also. So these related to the value of the devices overnight, the fact that they supported patient mobility, and some patients thought that the devices worked well. Some patients also had some concerns about the devices. Most commonly, these concerns were in relation to the perceived impact on nursing practice, the reliability of the technology, as well as discomfort. So in relation to the perceived impact on nursing practice, in 1 study there were some concerns that interactions with nurses would occur less frequently as a result of the wearable devices. In another study, some similar findings were reported, and some patients were actually concerned that the research could lead to the replacement of nurses. In relation to the reliability of the technology, some patients were unsure whether they could actually trust the technology. And in terms of discomfort, in 1 study 12% complained that the devices were actually uncomfortable. In another, 32% removed the devices prematurely due to discomfort or irritation. And there were some other concerns also. So in the study by Jeff's and colleagues, some patients removed the devices, again prematurely, and in this case some were too well or too confused or overwhelmed. So as I've discussed, the quality assessments revealed that the methodological quality of the quantitative studies was very low to low, with the quality scores ranging from 1 to 6 out of a possible 17, and the quality of the qualitative study was actually assessed as high. But overall, the limitations of the studies included in the review were in relation to unclear aims, a lack of randomisation. Most studies didn't report on patient compliance with wearing the devices, and overall the study measures were either poorly described or not described at all. So for example, in regard to validity of surveys, where any surveys were used, and there were also some concerns around reporting bias in some of the work. And really overall, patient perceptions of the devices were really only an a priori focus in 1 of the studies that we examined. So what are the implications of these findings for our practice? So our ability to generalise the research findings around patient perspectives of wearable devices is actually quite limited. So only 7 studies met the systematic review inclusion criteria, highlighting a significant gap in the research. So the implementation of wearable vital sign monitoring devices is still an emerging area in acute hospitals, and the research to date seems to focus predominantly on feasibility and the accuracy of vital sign measurement rather than patient perception. So at this point in time, the patient voice is largely absent from the literature. At a minimum, the variability in the results suggests that patients do have very complex needs and preferences regarding wearable devices, and we propose that the patient's primary diagnosis, the stage of their hospitalisation and the overall level of their acuity may be key influences on device acceptance, satisfaction and experience. And designers and manufacturers of wearable devices should consider partnering with patients to afford patients the opportunity to contribute to the development of wearable devices. So to conclude, there is limited high-quality research examining hospital patient acceptability of wearable vital sign monitoring devices. The success of these wearable devices is reliant on their appropriate application, which in turn is influenced by patients' tolerance of the devices. So further multi-site research of patient perspectives is needed to guide the use and development of wearable devices, leading to improved patient safety through the provision of patient-centred care. So thank you very much for your interest in our work. Are there any questions?